The following is a presentation of the Healthcare Facilities Network. Jim, you had talked about, it sounds like you guys are at the beginning of the process relative to, so I want to, you guys are,
very beginning.
so you guys are at opposite end of the spectrum in that, Clayton. I think you guys are pretty far along. Jim, can I go to you first though, relative to the very beginning? Kind of, what are you doing now? How are you developing like what's going on?
So we're at a very unique crossroads where we may be relocating our facility and we may be staying here. So we're taking both avenues. If we do relocate, it's a lot easier. A lot will be put in place with construction and with our choices. Whereas here, kind of working on a 5-year plan to get us rolling in the correct direction. We have done some things here in the past. We have the typical LED retrofits. We've gone to some heat pumps and so forth, but we're really in its infancy. And our big challenge is really going to be like the scope 2 and scope 3. Our equipment issues and our direct emissions are not that big a deal, but the scope 2 and the scope 3 are really going to be a hard dive for us, because that's where dollars matter. And that's where, it's great. And I was in Clayton's position once where our social responsibility could outweigh our fiscal responsibility to some point. But in a smaller organization, that fiscal responsibility is the driving factor, and it has to be the driving factor, because at the end of the day, we have 101 people to take care of, and their needs come first. Everything else is truly a support service. Mm-hmm. So, and that's where I think it gets really interesting, when you're direct care providers and when you have to weigh someone's direct care, against a mandate, be it fiscal, be it regulatory. That's really where the choices, it's going to be interesting to see when those choices have to be made.
Well, and I think, Clayton, we'll go to you next. From the outside looking in, I think that's what puts you in kind of that difficult position, because it's in theory, it's easy for senior leadership to get behind and support, because it's that social accountability and responsibility. But now back on this end, where where the tire hits the road, what does that mean? And so it's that balance. Clayton, where are you guys?
Yeah, I think that's you nailed it with social responsibility. We're a big player in this market, and we're a big name, and we have a responsibility as we spend money to either grow facilities or major capital investments. We should take that on as part of what we do. I think we're starting to see it. Again, pediatrics is strange, because our patients are really patient families, right? And so you have a patient that you're working on, but you're really supporting a family unit. And that family unit is starting to speak more about, what are you doing to be more sustainable? And they're asking those questions of us when we look at our survey results and things like that. And it's great for us to kind of go back to it. Again, though, if you really get down to it, every dollar you spend to be sustainable is a dollar that won't go to patient care. And making sure that, from a large capital perspective, and how we use all of our capital, that we balance that well. We could be a net zero hospital out here, but we don't have enough MRIs, right? Or we don't have enough, whatever that may be, to be able to support the actual mission of what we're here to do. So I think we've got to stay balanced. And there are times when we say, hey, we're going to have to kick that chiller replacement or that boiler replacement or something down the road a little ways, because I've got these other needs first. And that's why it's important that we sit there to be able to, sometimes you argue and fight for the money you need, but also recognizing that we're not here to build the most efficient hospital ever. We're here to take care of these patients. Yeah. Now, if we can do a little bit of both at the same time, perfect. And that's where we got to give and take.
Yeah, that must be one of those things where the goals and objectives, you must return a lot to what those goals and objectives are, just to keep it centered. And I've got to imagine patient care is going to be that center.
Right.
This is Peter Martin. If you or your organization is interested in advertising or partnering with the Healthcare Facilities Network, including sponsoring content, then please email me using the barcode in the lower right of your screen. From the trades level to the vice president level, from planning, design, construction, project management, compliance, safety, and security, the Healthcare Facilities Network reaches FM people where FM
Mark,
people
that-
are.
no,
What
it's
about your deferred maintenance? How do you balance those decisions Clayton was just talking about with that backlog of deferred maintenance? What's that process like?
Well, if Clayton has a hard time spending some money, just send it up here. We got a place to use it.
You got a Venmo code I can send it to?
So no, and he's absolutely right. We are taking care of patients. We've got, 3 main hospitals: Women and Infants Hospital, which is basically about 8,500 births a year, and we got a 40-bed NICU. That's primarily what that hospital does. We have Kent, which is an acute care hospital, and we have Butler, which is behavioral health. So, we kind of have a broad spectrum there. But again, at the end of the day, we're trying to take care of patients. And that's how I said earlier, I understand, when someone's saying, yeah, but we need an MRI, or yeah, we need a CT, or yeah, we need a robot in the OR, something along those lines. But with respect to the facilities and the deferred maintenance, it really has been, as I said, contingency. I do submit a 5-year plan, and but it's very general: elevators, nurse call, air handlers, boilers. It's not like, boiler number 1 at this hospital. And then I'm asked to kind of prioritize the need, if you will, when I put that number together. So I'm I guess battling myself or debating myself at times too, because boy, I really think we need to do this nurse call. Yeah, but I really think we need to do this boiler. So they're asking me, and I have to prioritize that. And then of course we live with the prioritization that we've made, and then look forward to the next year or the next quarter, if you will, to be able to say, okay, now we need to go in this direction.
Yeah. Are you looking relative to the initiatives for decarb and sustainability? Are you looking at a hospital by hospital basis and then measuring it against the system as a whole? How are you doing that with your multiple hospitals?
Well, at this point, I've been measuring it system-wide. I haven't been doing it by individual hospital. We do work with Rhode Island Energy with some of the projects that we've done to try to get some incentives or use their expertise to kind of say, hey, if you go in this direction or if you go in that direction, it may be a more efficient way to do it. We can give you some more incentives and things like that. But I do tend to measure it from a system perspective, because, 1 year, one of these hospitals may get, based on priorities, significantly more money than one of the others. So I try to do it on a system approach.
Okay. And Clayton, are you similar?
Yeah. We are looking at like the 2 individual hospitals, and then how does that roll up to a system level view? So yeah, that's, I guess that yes would be the right
Yes.
answer to the question.
Sometimes yes is that answer, right? What has been difficult? Has there been anything difficult to get your arms around relative to this topic and the task at hand? Has there been 1 or 2 things that have been particularly challenging to either get your arms around, and whether that's related to like team composition, education, how to go up, how to bite into this big mandate that's out there? Are there 1 or 2 particular challenges you've encountered, and if so, how have you solved for them?
But
Well, I think, my approach, I kind of wish we were asked kind of ahead of time, guys, when do you think you can do this? I mean, I'm looking at, what other regulatory things out there? If you look at pharmacy 797, 800, we got to do everything over with these pharmacies to get them where they need to be. And in some cases, those are hundreds of thousands of dollars to get them up to speed. And then we got another regulatory thing that may come down the road. And then all of a sudden we have this, and you think you've got your 5-year plan in place, and then you're handed another regulatory requirement, whatever it might be, and some different priorities go in place. So it would have been nice to be asked to have maybe a seat at that table, and maybe at the end of the day we did through some type of lobbyist. But again, it comes down to what I was saying earlier, Pete. If we could get the funding, there's no doubt in my mind we could get where we need to be. And again, I understand it. Been doing this a long time, and it's always been a competition with facilities versus everything else. We have just as much impact on the patient care as others. And some folks may not understand what we have to do. But if we don't have, proper temperatures, we don't have humidities, we don't take care of our pressures or our infection control issues, we'll hear about it on the other side. So
Yeah.
Yeah. Again, I gotta lean back into, we're fortunate. We're in a growth plan, so we have the ability to forecast out to what 2030 is going to look like and what we need to do to make that happen. But I think, as an industry, I think 2030 is going to go by, and there's you had said the number before, how many hospitals there are in the country and how many of those are critical access, single standing alone hospitals that don't, they're doing everything they can do to keep the door open.
Yeah.
And to say, yeah, we're gonna take that big bulk of hospitals. Yeah, my one hospital, my 5 million square feet may be meeting all the goals, but there's 10, 20x of that out there in the world who can't. And there's really no world. I think you had said earlier that subsidies are really going to be the only way to make that happen. Those hospitals are going to have to are going to have to be given some incentive, some subsidy, not punitive, because what else are you going to do? You just make them do it? Well, then, all right, we're going to have to close a unit. We've only got so many dollars to go around.
So, an element that I don't like about it, and we live in a society where somebody's got to be painted black, right? Somebody's got to be painted as the black sheep. And this number that we're responsible for 8 to 10% of the carbon in the world, that's not a reality. We're only responsible for our direct emissions. Scope 2 and Scope 3 is shared by your household, my household, and every manufacturer out there. All right. So healthcare is only responsible for that direct emissions. What is that real number? It's not 10%. And no one wants to publish that number because then you can't paint the black sheep. So, but we happen to be painted in this instance, and we'll have to go on from there.
What is the number?
I don't know what that number is. It'd be a very interesting number to know. And if you can come up with that 10%, you can come up with the direct emissions number. Everybody has an air permit, correct?
Yeah. So
if you just collected everybody's air permits, it would be a very simple equation.
You're right there. There is always we're always painting somebody in this society.
Yeah, and we just happen to be the painted ones here.
Because you got the 5 million square feet, or you had the 5 million square feet, Jim. Does the second thing I wanted to talk about and is relative to some of the problems you're having filling staff, and I know, Clayton, you're doing relatively well down there at Children's, but how much, just in general, how much does the staffing issue feed into the sustainability issue relative to and I know completing work, just hitting these goals of 2030, do the two interact, and if so, how do they play together or compete
absolutely
against each other?
No, if again, I've got staff who can dedicate time to being focused on it, and then and also drive initiatives towards it. If you are a typical hospital out there who's running on a shoestring on their facility side, the director is the one who's setting the capital plan. The director is the one who's looking at the emissions. All of that stuff falls on that one person. There's only so many places they can do, and
Right.
so only so many things they can really focus their time on. And back to what we said before, our job is to keep it running so we can provide patient care. And that other stuff out there, I'd love to be able to do, and I may have a passion for sustainability. Well, that means then I'm going to not do something else. And maybe that's not growing my team like I should, right? Or not being as engaged on the patient side. But it's all a give and take. And there's only so many hours in a day. And having the right team that can have the time to focus on that is the only way that's going to be successful. I've worked in those critical access hospitals, and they you do it all. And when you bring up this forward thinking, what we're going to do in 5 years, dude, I don't know what I'm going to do tomorrow. and try to get, I think that's the other challenge when you look at all of the bulk of the hospital square footage in this country are those critical access hospitals. And you're asking them to operate like I can, because I have that luxury, and they don't have the ability. Not that they don't have the drive or the want to. You just don't have the resources to do it. I have time to think about things that other people don't have time to think about, because I got other people thinking about things I used to think about.
So
Right. And we've done some recruitments for critical access hospitals, and not only are you wearing all those hats, but then sometimes you might be the one who's driving 120 miles between your two facilities, or driving to the Home Depot to get what you need. I mean, it's not like you're located in a central spot where you're just running to the hardware store, or you're going to your peer hospital. Jim, I'm sorry, I jumped in.
Oh, no, that's Peter. We have a line here. I believe you've met Melissa.
Yes.
Yes. So we have a line with Melissa. When she'll ask me a question, I go, well, I used to have somebody to do that. So I guess that's you or I now. So, and that comes up quite often. We call it the somebody line.
What do you, the somebody line?
Somebody line, yes, because every time she says something's due, I said, I used to have somebody to do that for me.
Okay.
What's
it
like?
Yeah.
If I could, Peter, Clayton said it very well, and it sounds like he's kind of lived the life that we're living now, and he's right. I have facilities directors that are doing probably some safety specs, some emergency management things. It's not solely on the facility side that they're doing it. But I'll tell you, my concern is more about where are we going to be in 10 years? I know we talk about nursing shortage, we talk about physician shortage, we talk about the stress that are on some of these clinical jobs, and no disrespect to them. But I think the facilities directors are quite frankly, in healthcare, a dying breed. And I think that's unfortunate. And where are we going to fill those positions? And if there are 6,000 hospitals, give or take, where are all these people coming from? Because, the Great Resignation, I can tell you, there are people that would go do education or manufacturing any day of the week than dealing with a facilities director who's got 16,000 regulatory requirements, whatever it is, from, Joint Commission to CMS to ASHRAE and on and on. So I think they're getting burnt out as well.
Well, I talked to you're exactly right. I mean, I talked to a lot of them, and that's exactly what you're hearing. And that's part of the reason, people ask us all the time, you're still recruiting, and we are still recruiting, but I'm putting a lot of focus on this network because it's a huge issue. I mean, if you don't have people, what do you do? I mean, we have hospitals at the cornerstone of every community in America. Who's running them? And if you guys leave, what are you left with? So we can keep talking about it, but we got to do something. And whether that's, reaching out to that next generation, publicizing that this career exists. I mean, listen, you guys are talking about everything you have to do, yet you're still saying you love doing it. Think about that. So people need to know that, and to publicize. Jim, I jumped in that little soapbox.
Oh, no problem.
Go over to you.
But just to build on that, I thought about this last night. I happened to be married to a nurse for a very long period of time. I entered the healthcare industry with the building collapse of 1984. I was a plumber by trade. And when I became a plumber at Dover General Hospital, I was making 5% more than any RN at Dover General Hospital. Today, our average nurses in New Jersey are making 30% more than our average skilled tradespeople. So it's, we still are support services, and we can say all we want about mentoring and bringing people in. Until we somewhat change the finances of this, we're always going to have people looking at other opportunities other than facilities management, be it healthcare, higher ed, or whatever. So, and I think this is where we really need to focus, that bottom up, because if we're going to raise from the bottom, we need a bottom to raise.
Yeah, right.
And we don't have that bottom. When I left Rutgers, I was down approximately 24 positions in Newark. And we had gone from, we would post a plumber's job in, say, 2014, we would get 70, 80 applicants. After the pandemic, we're getting 4 and 5. So it's got to be a bottom up effort.
Yeah. Yeah.
We definitely
Grade
lean
school.
into, I think you make a great point about the comparison to the nurses, to the skilled trade folks. And that swing definitely happened, right? One of the things that we're fortunate to lean into is we've got our HR team has made a benefit package mainly to recruit nurses because we had such a nursing shortage after the pandemic. That focused on things like maternity leave, caregiver leave, education reimbursement at 100%, all of those things trying to grab nurses. And we turn around and take it to those, same thing, right? You were married to a nurse. Happens to be a lot of tradespeople end up being, in that same demographic. And we say, hey, we can give you all those same benefits that we give those nurses, and be able to lean into that to where we can attract that guy. I think our sweet spot is that, late 20s, early 30s, been working in the field for a long time, and it's 108 degrees for 100 days straight in the summertime. And like, hey, we're air conditioned all the time.
Oh yeah.
And it's easy. Then they're like, oh wow. And you have a regular schedule. You work, you don't get rained out. You don't, all of those things plus benefits. And, it's funny when I talk about that with some of our tradespeople, they're like, oh yeah, that's 100% why I'm here. I can make more money out on a truck, but I know exactly what I'm gonna get paid every day. I know exactly where I need to be. I've got all of this stuff around me that I wouldn't have out there. And I think we've lost a few to go do that because they're chasing the dollar bill. But once you get into that kind of into a groove of your life, and I've got a family, I've got kids, or I'm going to grow a family, leaning into those benefits has been what's helped us. But helped us. But we have the exact same issue you have. We post a plumber position. We may get 4 applicants, but we've got to go find them because our HR team is going to post it on LinkedIn or Indeed, and then expect us to get a whole flood of applicants. Well, most plumbers don't look at Indeed for a job.
And so it's interesting because it's kind of what's old is new again. I stayed in healthcare because at that time, I don't know if anybody was in healthcare in the 80s, you didn't pay for health insurance.
Mm-hmm.
We had benefits that no one else had. And that was a huge attraction. Then over the course of time, and I think this happened more on a regional basis, with the tri-state area being one of the worst. You started losing those benefits because benefits became expensive. And now we're trying to get them back in. And I agree with you. One of my lines is when I was at Rutgers was we don't offer the same benefits anymore. We're not losing people for the salary. We're losing because we don't give them that solid benefit package anymore.
Yeah. I'm going to be doing an upcoming episode talking to a VP of HR from outside of healthcare about work-life balance and what they do and how they do the remote stuff. Only because I think it's Grant, you guys can't copy it, verbatim, but just to get some other thoughts, what are other people doing? What might you be able to do? Because that's certainly a benefit too. We're coming up against the clock. So what I want to do, this went by really fast. Anything that we didn't touch upon or anything that you had prepared you wanted to get to relative to sustainability employee? And if the answer is no, the answer is no. But since it kind of came up really quickly, I just want to give you guys last chance. Anything you want to add to the discussion that we didn't touch on?
I would just say thank you for the opportunity, Peter. I'm sure there's many folks out there that are dealing with the things that we're dealing with, and hopefully been able to shed a little bit of light for them.
Yeah, I second that. I really appreciate this opportunity. I think it's always funny when we get a bunch of facility guys in a room together. We all have basically the same story, but we love telling them.
No, and thank you. It was very enjoyable.
Yeah, no, I appreciate it. I knew you guys would. I knew you would talk well because I kind of know you all independently. So I appreciate that. So our guest, Mark Yerrick, Clayton Smith, Jim Campoli, thank you so much for your time. Peter Martin from the Healthcare Facilities Network, as always, thank you for watching and have a great day. Bye now. Thank you for watching this episode of the Healthcare Facilities Network. Please give this episode a like, as it really does make a difference in helping to promote the discipline of healthcare facilities management.